All right, so right now we're going to talk about using EPI as an infusion. So this is indicated in our refractory hypotension. So what refractory hypotension means is we've attempted to position our patient, we've administered fluid boluses, and we're getting no response or not enough response. We still have a systolic blood pressure less than 90 or a MAP of less than 65. All right, so to meet our objectives, there's a few things, a little bit of groundwork we got to lay out. First thing we need to do is obtain IV access. If you intend to use this administration or this infusion, we need to make sure we have IV access in the AC or higher with a large bore catheter, so an 18 or a 20 gauge. So we want to establish this, run our fluids, our normal saline, make sure it's patent, we don't have any extravasation or anything like that. All right, so our IV line, we've established it, we've made sure it's patent, it's flowing, and we don't have any issues with it. Then we can go ahead and get started with our EPI infusion. All right, so a few different things we might need for it: a 60 drop administration set or a mini drop set. We prefer using a 250 milliliter bag of normal saline. It makes an easier concentration to manage. We're going to need some tape, code EPI 1 to 10,000 or 0.1 milligram per milliliter, and an 18 gauge drawing needle. All right, so we'll go ahead and we'll spike our EPI bag just like normal and make sure it's clear that we're spiking this bag with a 60 drop set or a mini drop set. All right. So there's no change in this process. We're going to do this just like we normally would. Spike our bag, fill our drip chamber. If you're able to see this on the video, remember, fill it up to about halfway. Try not to fill it all the way to the brim if you don't have to. And then we'll flush our line like we normally would. And now flushing our line. So we flushed our line. This thing is ready to have the drug administered into it, and we can start to make our actual infusion. So we take our bag, and the first thing, before we even put anything in it, what we want to do is take that tape that we mentioned earlier, and we're going to pull a strip off and label this bag so that there's no confusion. Because at this point, prior to this tape being placed, this looks like a normal saline solution. We don't want any confusion if there's any handoff or any change in providers, or if maybe we forgot. We want to make sure that at least somebody can figure out or discern that this is something different. So we prefer you write EPI Infusion on it, or EPI INF, or some sort of just writing EPI on it. That might just do the trick, all right? We need to make sure this is clearly identified for anybody and for yourself even, just so there's no confusion. All right. To administer your EPI into there, you're going to take your code EPI. And I want to just cover a few things. EPI is going to come a million different ways. It's on shortage always, so sometimes you may have this type of administer with a green tip on it. Sometimes it's just the plain Luer lock tip. Word of caution, with this type of Luer lock here, you have the option to unscrew this green cap, and it has a medication administration needle on there. What we've found out, unfortunately, with this type IV bag, this type of port, it is not compatible. So please do not use this for this type of port. Make sure you're familiar with your equipment and how it's going to work in this type of scenario. So if you do have this type of EPI, just take the little green cap off and attach your syringe to the Luer lock like another one, okay? So now it's essentially the exact same thing as this one. So we'll go ahead and attach our needle to our EPI thing. We'll attach our medication. Again, this is EPI 1 to 10,000. We're going to get the air out of it just like we normally would. And we're going to instill this into our IV bag. We're going to administer the whole thing. We're putting 1 milligram of EPI into a 250 milliliter bag of normal saline. This is going to give us, after we put this in our sharps container, a concentration of 4 micrograms per milliliter. Okay? So we're going to slowly agitate this bag. We don't want to shake it. We don't want to create any bubbles, but we do want to make sure we do have a mixture. Okay? So after there, we can hang our bag. And we're ready to begin. So just to be clear, this line, our normal saline, our liter bag or 500 milliliter bag, is in our patient. This is flowing at a TKO rate, or maybe you're still bolusing. Whichever it is, it's on, it's flowing to make sure our line is still patent. We didn't lose that. Our patient didn't move since last time we checked it. We want to double down, make sure that is a clear and patent line. What we're going to do is piggyback a medication. So we're going to shut down our normal saline line, and we're going to take our EPI infusion, and we're going to piggyback it in. So this is putting it in the IV line to our liter bag. All right. There's no occasion where you should be running an IV or an EPI infusion directly into the IV or IV lock setup. You need to have normal saline there in case we need to change this out or replace this or bolus our patient. Okay, so to suspend reality a little bit, this is now going to be connected to our patient. And then we're going to run our drip. Be warned, this is it's not the easiest procedure. When we're looking at drips, we don't have pumps or any automated way to do this. So our dose, our starting range for this medication for our refractory hypotension patient is 2 to 4 micrograms per minute is our starting dose. So with a 4 microgram per milliliter concentration to start at 2 micrograms per minute, we're going to run 30 drops per minute. All right. So to get 30 drops per minute, that's 1 drop every 2 seconds. Okay. So 1 drop every 2 seconds. We're going to start very slowly rolling our wheel up until we see our first drop form on the end of our needle. All right, so then 1,000, 2, 1,000, 1,000, 2, 1,000. So we're about 1 drop a second right now. So we're going to just ever so slightly pull down. So 1, 1,000, 2, 1,000. There's my drip. Okay. So this being said, this is in an extremely controlled environment. We are not moving. There's no swaying back and forth in the ambulance. I am not actually in a vein of a patient, so I don't have to worry about my patient flexing their arm or moving or the IV becoming infiltrated or anything like that. So this is a very focused procedure. We need to keep checking up on this and monitoring this. It's a powerful concentration of a medication, so we need to be concerned always anytime we're using an epinephrine infusion. We can create tachycardia, hypotension, increased myocardial oxygen demand, and we can create dysrhythmias or arrhythmias. So we need to really be keen on our patient status if we're administering this. We're only going to get their blood pressure up to a systolic of 90 as appropriate, or a MAP of greater than 65. Okay? If we need to move up to 4 micrograms a minute, let's say 5 minutes has passed and we're just not to where we need to be, we're going to increase this to 1 drop a second. That gets us 4 micrograms per minute. So 1, 1,000, 2, 1,000, 3. So now we're there, and you can use your watch if you want to make to try to get as close as possible. All right, and now 2 to 4 micrograms per minute is our starting dose. We do have the ability to titrate up to 10 micrograms per minute. So we're going to give you some information further in this presentation that's going to break down kind of an easier way to know how many drips per minute versus how many drops per second are we going to do. It's a little difficult to work out in your head, but a key thing here is you don't want to rush this patient. All right, this is a powerful concentration. Give it time to work. Epi has an effective dose curve, right? So we need to let this run 5 to 8 minutes before we start running this up even higher and higher. Okay, you don't want to say, well, it's not working at 2, let's go ahead and jump to 10 real fast, because your patient's going to possibly end up in cardiac arrest because you've overloaded the heart at that point. So be very pragmatic, very careful with this solution. And at any course in time, there is an issue. You notice your patient is tachycardic, throwing dysrhythmias, any extravasation or anything like that, shut down your line, close it off, and we're going to run our normal fluids here that we've already established with our normal saline. And that should do it.